So today we'll be discussing the current healthcare crisis in Australia. Our first speakers, Danielle Romanes and Peter Breadon, will talk about the recent Grattan Institute report authored by Dan. A New Medicare is strengthening general practice. Danielle was a visiting fellow at the Grattan Institute in 2022, while on leave from the Victorian Department of Health, where she's Director of System Reform. Peter is the Health and Aged Care Program Director at Grattan Institute. He has worked in a wide range of senior policy and operational roles in government, most recently as Deputy Secretary of Reform and Planning at the Victorian Department of Health. Over to you, Danielle and Peter.
So we already heard in the introduction the sense that there's a crisis in Australian healthcare, and I think that's widely accepted now. And we'll go through some of what that problem is. So what is going wrong? It's not as, I guess the first thing to say is a lot of people at the front line in general practice, which was the topic of our report, a lot of those GPs feel burnt out, stressed out, disrespected, burning out. And some of these colourful quotes on this page are just a snippet of some of the media reporting and commentary that GPs have said that they're disrespected, they often fear government trying to claw their income back, and they feel like they're bearing the brunt of this healthcare crisis with little support. So a lot of early commentary last year was that the problem was we didn't have enough GPs. They were stressed out because there weren't enough GPs to do the work. But while there might be a shortage today due to the really acute surge of demand from the pandemic, particularly after restrictions were eased, with many hundreds of thousands of cases throughout the community in the last few months, and also rising levels of long COVID, there's real shortages in the system from some of those pressures today, but there's not a long-term structural shortage of GPs in Australia. No matter what measure you look at, it seems that that's not the real problem. So this chart here shows you that patients who report that they waited too long to see a GP, that proportion had been trending down over time. And just before the pandemic, it was down around 17%. And you can see it just shot up in that next reporting period, which I think reflects some of those pandemic pressures. Shown in the box on the right are some other measures that suggest we have an ample supply of GPs nationally. So we've got more GPs than we had in the past. We've got more GP consultations per person than we had in the past. We've got more GPs in training than we had in the past. So we realized, looking at those data, we have to look for another problem that's creating all these stresses and pressures in the system. And that problem is the changing disease profile of the community in Australia. Medicare was dreamt up in the 60s, implemented in the 80s, but since then rates of chronic disease have risen substantially. This chart on the left shows how many of those have risen a lot over time. Some of them, like mental health concerns and osteoporosis, doubling, diabetes going up, as you can see there, by 50%. And when you combine Australia's very long life expectancy with those rising rates of chronic disease and more people having multiple chronic disease, you end up with a lot of people living a long time in ill health with complex health needs. The chart on the right shows that the proportion of life spent in ill health in Australia is among the highest in the world. But at the same time, as patients have been getting sicker and more complex to treat, with ongoing chronic diseases where they really need their care team to teach them to look after their own conditions, educate them and support them to manage their health. So with all that complexity increasing, this chart shows here that in the last 10 years or so, GP visits are getting more complex. The rates of those issues like chronic illness, mental health concerns, older patients, that's all going up substantially. But the blue line shows the average length of a GP visit, and that is stuck at or below 15 minutes. Despite that rising complexity, GPs are feeling rushed and trying to cram in ever more complex care into that short, unchanging span of time. The second problem, so the first is much more complex disease and more of it, and GPs don't have time to manage it all. The second problem is the care is not distributed equitably. So each of these little dots on this chart represents a small area. and they're ranked by the proportion of people in that area over 65 who didn't see a GP within a year. And you can see that most of those little dots are down the bottom there, suggesting that in 2/3 of neighbourhoods across Australia, everybody who's older is seeing a GP at least once a year. But in some areas, 5%, 10%, or even 15% of people aren't seeing a GP who are older, which suggests that some people are really struggling with access. We don't have a GP problem nationally, but we do have a GP problem in how they're distributed across parts of Australia. In a lot of other countries, allied health, like allied healthcare for mental health, such as psychologists and counsellors, they are inside general practices. Not so much in Australia. And here again, you see that the distribution of these allied health services for mental health, they're not where they're needed most. So the left-hand orange chart, that shows that in the poorer areas, the rates of psychological distress are double the rates in the richest areas. But perversely, there's half as many MBS-funded, Medicare-funded allied health, mental health services. So here we see this big distributional problem, both with GPs, some areas missing out, and then with allied healthcare, poorer neighbourhoods particularly missing out. So if we've got the problem of GPs struggling to fit in all the chronic disease care, with healthcare workers not being in the neighbourhoods where they're needed most, what is stopping the system from responding? So these are 5 broadly accepted international principles about what makes good primary care. So a focus on chronic disease is the priority. It is the biggest and fastest growing disease problem in Australia and most similar countries. Self-management being the goal of care, helping people to manage their own disease between visits. Integrated care that brings together the different services people need. Giving patients continuity with the same team over time, which has been shown to improve health outcomes and make people live longer as well. And finally, multidisciplinary teams, bringing together all the different care people need and providing it together as a group. So those are the 5 directions. There's lots of evidence on this. Every country is trying to move in that direction, including in Australia. That's where our policy is trying to head. But there's a few problems. The first is that team. I mentioned multidisciplinary team-based care. The team in general practice clinics in Australia is much less diverse and less multidisciplinary than in other countries. This is one example. So here, about 3/4 of clinicians in general practices are GPs, the other quarter being mostly nurses. You can see in the UK, it's closer to half that are GPs, with a much more diverse team supporting those GPs, including pharmacists, paramedics, nurse practitioners, and administrative assistants, and so on. And here's the result of this. So you can see that each dot here is a country, and this is a survey that asked GPs, do you have someone in your practice who can independently handle some of the less complex tasks? Australia is the orange dot below the median country. So compared to other countries, we're less likely for GPs to report, yes, someone in my practice, such as a nurse, can handle a minor procedure, like syringing someone's ear, a health promotion, giving people some education about how to stay healthy, vaccinations, routine checks of chronically ill patient. So it's another indication here that we don't have that multidisciplinary team that can share the load with GPs. Even the workforce we do have in general practice is not used to its full ability. So I mentioned we have about 1/4 of the workers in general practice clinics, they're nurses, but a lot of those nurses say they don't get to use all their skills. So only 1/4 of them, when they were surveyed, said there were no barriers to them using all their skills. Half of them said there were 3 or more, up to 10 different barriers, all the ones listed, stopping them being able to contribute fully to the care of patients. So that's gone through some of the workforce challenges, not enough people around GPs supporting them, and even those people who are don't get to do as much as they could. The other big blocker is our funding model. So this chart shows here the 4 big main types of services GPs are paid for, and they're paid for by a length of time. And the curves on the chart, they show the dollars per minute that a GP gets. So for a short 6-minute consultation, the GP earns nearly $7 a minute. For a 30-minute consultation, it's only about $2.50 per minute. So no wonder GPs are under financial pressure to rush through the visit as fast as they can, despite the care needs getting more complex with time. So this is clearly now a mismatch for the new disease burden that Australia has. The other thing about the funding model is we know that all the things in this chart drive the length of consultations. So these are all things that make a GP visit, on average, take longer. And the funding model simply doesn't take these things into account. To go into a few examples, These orange bars basically reflect clinical complexity. How sick is someone, and therefore how much support and guidance, diagnosis and treatment do they need? You can see that having more problems, having chronic disease, these things add length to a visit of 1 to 2 minutes. And similarly, social pressures, disadvantage, that tends to lead to longer visits too. So this social problems is the standout that adds, 5-6 minutes on average to consultations. It's likely associated with disadvantage. But perversely, in our system, these red bars, GPs on average spend longer with wealthier patients, which is again a function, a representation, a reflection, I should say, of the maldistribution of resources in our system. Other countries no longer do it this way. We're one of the last countries in the world that have this fee-for-service system that focuses on churn and volume and that doesn't adjust the funding according to the patient's need. You can see here there's these 5 countries on the left, including Australia, which still mostly rely on fee-for-service for general practice funding. The other 4 there all have very different systems to Australia, social insurance systems. And then all the countries on the right-hand side of the screen, they use a blended funding model. That brings together some retained component that is fee-for-service, but it puts another budget on the top, a flexible budget for the patient. And that budget is adjusted for the patient's need so that sicker patients get more funding. To give some examples, I won't spend much time on this, but other countries build these things into their funding model. So in Denmark, the way they fund their health system, they will pay more for patients who are older, who are living with some forms of social care, or who are renters instead of owners, who live in an area that is where the population is sicker, who have severe mental health conditions, etc. We don't make those kind of adjustments in the way we fund care in Australia. Similarly, at the patient level, other countries make big adjustments. This is the case of New Zealand, and you can see here the way they fund care in New Zealand takes into account the level of deprivation of the area the person lives on, with more funding for people who come from poorer areas, because those people are on average sicker and face more health risks. And they also pay more for people from a Maori and Pacific background. The third problem, so I've gone through the workforce, the team is not diverse, and the team is not used to its full ability. Second problem is our funding model promotes churn and doesn't fund people for looking after the sickest patients. And the third problem is how the system is managed. So in Australia, we have these primary health networks, regional bodies, there's 31 in Australia, and their job is to manage and improve the primary care system, including GPs. So they're supposed to work out what's needed, make sure that's being purchased, monitor performance, and work with the community to understand the needs and make sure they're being met. But these bodies rely on a set of guidance and policies from the national government. What should we be trying to achieve? What are the models of care we should be rolling out? What measures are we trying to track to make sure we're getting results for people? All of those national settings that the PHNs, the primary health networks, are working within limit their ability to do their job well. There's not a clear direction for the system where it's going. They only have, these primary health networks, 2% of primary care funding, so they can't really shape and improve the system the way that they're supposed to. And performance measurement is very poor. It doesn't really track the things that matter to the outcomes that matter to patients. So they're the 3 big problems that at this topic changed: the workforce model, the funding model, and how we manage the system locally. Now I'll stop sharing my screen, and I'll hand over to Danielle, my co-author on the report, and she will take the more glorious job of now talking through all the solutions and how the system should be fixed. Over to you, Danielle.
Thanks, Peter. I've already spoken on mute, but hopefully it's the only time tonight. Now, can I check if my screen's sharing okay? Great. Okay, so a big question, what should we do about it? The report recommends that we basically fundamentally change the way that general practice is provided to deliver against 2 goals. So one is that people who are sick and who need more from the system need to be able to get more time with their GP or their care team. But at the same time, we need to reduce pressure on GPs because the strain is too much. So to achieve that, we recommend a new way of forming a general practice team. At the moment, the model everyone is familiar with is the 15-minute consultation. You roll up, you go to the general practice, you're greeted by a receptionist, and then you spend about 15 minutes with your GP. You try to squeeze in about 45 minutes of content into that, and you get what you need and you're sort of on your way. But we recognise that that's increasingly unsustainable. There's just too much to cover in those consultations. Patients aren't getting all the preventative services that they need. There's no time for it. And patients aren't able to close the loop with their GP and do the follow-up that they need to ask really detailed questions to confirm their understanding and check in, crucially, in between appointments.
Danielle, sorry.
Danielle,
Just gonna,
you might like to change your PowerPoint to, is that what you're going to say, Peter?
same thing. Yeah, just into presentation mode. Yeah, that's fine.
So sorry, here it is. How's that going? So this is the old model. What we recommend is something very different. It's a teamlet structure where, in addition to having a long-term relationship with a GP, patients also have a relationship with a medical assistant or nurse who works with that GP to support them in their role. So the appointment looks a little bit different then. When you arrive, you meet with the medical assistant or the nurse, you go through the history, you confirm your goals for the appointment, you talk about medications you're on, blood pressure measurements, weight measurements, whatever is required. When the GP comes in, it's for a shorter amount of time, focused on things that are within the GP's key remit. So diagnosis, treatment plan, the things that their training best prepares them for. And when the GP leaves, patients are able to kind of close the loop with the medical assistant or the nurse, ask questions and really go through the detail of the plan and do coaching. It's really focused on empowering patients to self-manage their conditions because we recognise that's really what's core to the management of chronic disease. The GP is not just supported by a medical assistant or a nurse. They also have access to secondary consultation or expert support from other specialists. So, for example, being able to call a psychiatrist who talk about medication or prognosis or approach for their patients who have mental health challenges, endocrinologists for diabetics. We have really good evidence from around the world, but particularly from Australia from randomised control trials, that specialist supported general practice care is what's really effective in improving outcomes for people with chronic disease. And of course, there's other support based in the practice, including clinicians such as pharmacists, physios, paramedics, an emerging model in the UK, and psychologists. There's a much bigger team on place to share the load with GPs and ensure that patients are getting their needs truly met. Of course, that's a wildly different model of care to what happens in general practice at the moment, and it requires broader system reforms to make it possible. So we recommend a broader suite of reforms across workforce, funding, and quality management of the system. So for workforce, first, reviewing and removing regulatory barriers that prevent workers from using all of their skills that we recognise as really prohibitive at the moment. Turbocharging change by tying salaries for new investment, so 1,000 new workers in areas of need, including nurses, but also pharmacists, physiotherapists, and psychologists. Really kind of kickstarting that new model. Funding new specialist advice to help GPs manage their more complex cases. On the funding side, we recognise that fee-for-service is a major barrier to this approach. Fee-for-service only pays the GP and really strongly discourages sharing of care in the way that's demonstrated in the prior slides. So we need a blended funding model, as Peter talked about, that's increasingly commonplace around the world. The MBS schedule needs to not just fund GP care, but also care provided by nurse practitioners and physician assistants in participating clinics. So obviously a lot of barriers at the moment to even nurse practitioners who are pretty well established from having all of their work covered. And critically, we need to fix access gaps in rural areas. So plugging services in areas of market failure and supporting GPs who are really overwhelmed in many of those areas to operate more sustainable business models. And we recommend a bigger role for primary health networks in that space. And then, of course, as Peter mentioned, a stronger role for system managers. So the Commonwealth needs to clearly articulate what its vision is for the primary care system, develop a digital and data strategy that overcomes major challenges in that space, and role changes out through primary health networks so they can shape the system. And then lastly, of course, measure what matters, so quality, outcomes, and experience for both patients and clinicians, so that the system can be measured and general practices can be accountable for the funding they receive and for improving care. What we've really recommended is that the Department of Health at the Commonwealth level really learn from the past. So this is not the first time that new approaches to primary care have been tried. It's sort of a recurring theme. In the report, we talk about more pilots than Qantas, just littering the general practice sector over the last 3 decades or so. So 4 attempts, coordinated care trials, which some people on this call may remember, first phase 1 and 2, the Diabetes Care Project more recently, and then healthcare homes under the previous government. One thing we highlight is that often discussion about primary care reform can be, I guess, negatively tainted by the experience of healthcare homes, which was very dissatisfying for the general practice sector, as well as for many users. There were very, very high rates of attrition of general practices participating in the trial, and really no meaningful, sustainable improvements to speak of. But all is not lost, because there are a lot of valuable learnings from prior trials, particularly like to call out the Diabetes Care Project, which wrapped up just in 2014 and was beginning to show really significant improvements in outcomes for people with diabetes, obviously a really serious life-impacting condition, including measures like reduced weight measurement, reduced blood pressure, reduced psychological distress, and then very significant improvements in blood glucose control among the patients who had the worst blood glucose control to begin with. So really life-changing impact. And certainly my strong belief that if the project had persisted over a longer time frame, it was only a couple of years, you would have seen big reductions in hospitalizations and costs. So we know it can be done. We know that improvement is possible. And there are really important learnings buried in these evaluations that the department can work from when it starts again. To succeed where other pilots have failed, there needs to be a strong focus on changing for the long term. So not just, a pilot every couple of years and continuously sort of reinventing the wheel, but not really getting any further. So there needs to be really comprehensive engagement with the general practice sector, and extensive planning to ensure that the model that's developed in partnership with general practice is viable. We're going to start with the willing and able. So not everyone is going to want to significantly change their business models, and that's okay. This is about starting with the willing and working from there. Intensive change support, so recognizing that there are enormous transition costs for general practices and fundamentally changing their employment models, their billing models, and the ways they work, and they need to be supported to undertake that change. Then, of course, the long-term commitment. So not just committing funding for 4 years, but having a multi-year funding cycle in place that gives confidence to the sector, as well as the community, that there is a real commitment to change. And then, of course, build and review points. So it's not possible to get anything right perfectly from the outset. So there needs to be a willingness and openness to review, to understanding where there can be improvements, and continuously adjusting the model, particularly the funding model, as they go. So we really recommend a multi-year strategy over 2 terms that would scale up from just 100 practices to start to about 1,000 in 4 or so years. Now, that's the end of the slides. I'm sure there are lots of questions. I think some have been coming through already. So I will stop sharing, and will you take questions from here, Fernanda?
Your very interesting presentations, which I believe has set the field for John Furler, who will give us his perspective as a GP working with community health. John Furler has been a GP at North Richmond Community Health Center since 1994. Previously, he worked in general practice in the UK and in Aboriginal community-controlled health services in the Northern Territory. He's an honorary professor in the Department of General Practice at the University of Melbourne, where he has maintained a strong research focus on the nexus between chronic illness, socioeconomic disadvantage, health equity, organization of primary care, public health, and prevention approaches. And I will also add that I have had the pleasure to witness firsthand the amazing work Dr. Furler does, and how their work can impact and change lives. So thank you so much, Dr. Furler.
Thanks, Fernanda. I'll just try and share my screen, make sure I get that right. Is that okay? It's on a presentation mode, is that right?
Yes, it's perfect.
Okay. Yeah, look, thanks very much. And thanks to Peter and from the team about from the Grattan report. It's really terrific. It's wonderful to be here. Thank you for inviting me. As Fernanda said, I'm going to contribute to the discussion from the perspective of general practice as a GP. I can see there's lots of GPs in the audience, which is terrific. I have been involved in researching health equity in the past, and I have a long association with working in community health, so I'll certainly be drawing on that. I know the Fabians focus on social justice, equality, collective action, and public service, so I'll really try and think about or say something about how general practice and reform in general practice can contribute to that. I'll talk briefly about my background, although that's briefly been alluded to by Fernanda, thank you. Then I'll make a couple of points. I'll focus on the notion of inverse care in general practice and give a personal view about that around its qualitative and quantitative aspects, and link that to equity weightings, which has already been mentioned. And then I'll give two reflections on the new model of care that I think is being proposed in the Grattan report, and also through the Strengthening Medicare Task Force, I think, as well. And I'll touch on this notion of generalism as a strength of general practice that I would hate to see eroded, and I think needs to be part of the discussion, but I'll certainly talk a lot about community-controlled health organisations and general practice, and finish with a few recommendations about key ways forward. So here's a few photos. As I said, I am a GP. I'm from Adelaide originally, but I did my GP training in the UK, in the NHS. That's up in the top left there. That's on the Walworth Road near the Elephant and Castle. It was in a very mixed housing estate. There was a mixed demographic not far from Parliament House. But anyway, I came back to work in Australia, and I worked about 4 years in Aboriginal community-controlled health organisations, both in Kakadu for the Gagaju people and Danila in Darwin. And in '94, came to Melbourne. That's a picture of Richmond there. I work since then at North Richmond Community Health Centre in inner city Richmond. And throughout that time, since 1996, I also worked at the University of Melbourne, involved in health services research and health equity research, but I'm an honorary there at the moment. But primarily, I'm a GP. That's important to remember. And certainly as a GP, it's pretty easy to see that the Australian healthcare system is problematic. It's fragmented and very confusing for everybody. And it's particularly fragmented and confusing for people with complex multi-morbidity who need lots of different services from many different care providers and organisations. And those most at risk are, particularly as Peter's alluded to, people who have coexisting physical and mental health problems, socioeconomic disadvantage, low health literacy, very few resources. The challenges in finding your way are enormous. And the inverse is equally obvious, that patients with plenty of money, high health literacy, plenty of resources, they can much more easily access a very wide range of health professionals, tests and pharmaceuticals within this fragmented fee-for-service system that we have. So from my point of view, there is inequity built into our healthcare system. And inverse care, which is a term coined by Julian Tudor-Hart, a GP in Wales in the 70s, describes one way in which that inequity plays out, with the least care being available to those who need it most. But importantly, this notion of inverse care, I think, applies to, in both a quantitative way, the amount of care people get, access and timeliness, but it also applies in a qualitative way to the experiential, to the experiences of patients and what sort of care that they receive. Now I'm going to show a couple of slides which overlap a little bit with what Peter said. Importantly, one slide is from the UK and one is from Australia, okay, reflecting on this notion of inverse care. So this data is from Stuart Mercer, a colleague in Glasgow. On the left is a graph showing the levels of psychological distress in high deprivation groups compared to low deprivation groups at any given level of multi-morbidity. So it doesn't really matter whether you're, you have one, two, or three or more coexisting illnesses at any level of multi-morbidity. If your socioeconomic deprived or disadvantaged, your level of psychological distress is much higher. And yet, despite this need, as we've heard, if you're from a high deprivation group, you're much more likely to get a short time with the GP. Whereas if you're from a low deprivation group, a more advantaged group, you're more likely to get a long consultation time with the GP. But importantly, that's reflected in Australian data. This was one of my early studies that I was very proud to be involved in. We analysed 2 years of Medicare data and essentially found that people from high levels of disadvantage were 40% less likely to access long GP consultations compared to the most advantaged postcodes in Australia. The 20 million data set, items across each of those 2 years. So the important point about the UK and the Australian data is that the UK, of course, is a blended payment system, not a fee-for-service system, whereas in Australia, it is a fee-for-service system. So it suggests that possibly it's not just about the amount of money coming to you as you churn through people. There may be something more to that going on. So I think that's an important point to keep in mind. But as I said, in these rather pressured circumstances, the interactions that people, so just to summarize, GPs are working harder in both those systems. They're trying to see people more often and see them more quickly, and the result is this mismatch of care to need. So in those sort of pressured circumstances, the interactions that people have, people from more disadvantaged backgrounds with their GPs are quite different. So this is based on work from Sarah Willens in the Netherlands and work that I've done. Low socioeconomic patients, people from those sorts of backgrounds receive less positive socio-emotional utterances. They receive more directive sort of utterances from their GP, less participation, less information giving, less partnership building. People from high SES backgrounds are more actively communicating, showing more effective sort of responses in a consult, and they elicit more information from their doctor. So consequently, the clinical care that people from more disadvantaged backgrounds receive is more utilitarian. They get more prescribing, they get less referral, less sort of engagement. And my own work, which looked at the way that GPs use this notion of patient-centeredness in consultations in relation to the social class and social background of patients, showed that GPs tend to selectively use the breadth of a fully patient-centered consultation style in patients that they perceive as being from high socioeconomic backgrounds, who have high health literacy and high resources available to them. So there's definitely an experiential qualitative aspect to this notion of inverse care. And certainly, as has been said, waiting payments is absolutely critical. And I want to make it, because I want to finish on that point as well. Whether you're waiting basic payment systems or payments for quality improvement or pay for performance to reduce inequity, to improve quality, you need to wait payments to reduce inequity. Now, this was actually from a report that we made to a House of Reps standing committee into health and inquiring into chronic disease prevention and management some years ago, very similar to what's been recommended in the Grattan report. Equity weightings must be applied to all elements of any sort of blended payment system in general practice. They must target both clinical complexity and socioeconomic factors. I'd favour the latter being given priority. And the infrastructure already exists for this. You could do this tomorrow. You could target some resources to where the need is higher, and you can do it with small mesh blocks of data linked to patient's address, and it's very easy to sort of arrange. And in particularly in relation to quality improvement payment systems, I want to emphasize that pay for performance must not penalize practices who are starting with low levels of quality markers because they're already working with very disadvantaged and clinically complex populations, whether that be in Aboriginal community controlled organisations or the like. So, where I went, so let me get back to what I was saying. So, who wouldn't? The Grattan report has made a very, very strong case for a foundational shift in the way we provide general practice and primary care. And of course, who wouldn't want to change from this more traditional cottage industry picture seen on the left here to the modern, integrated, multidisciplinary, connected, data-driven primary healthcare centre of the future. We could characterise these two different models as seen here. So the traditional model, small scale and local, there's continuity provided through ongoing knowledge and relationships with the patient and the family. The practice itself has a small family or structure, little management involved, and the values embedded in that practice are loyalty, integrity, relationship-based, and self-sufficiency. In contrast, the contemporary sort of model, and I'm caricaturing these, you know, it's a large regional multi-site sort of network. Continuity is provided through information systems, the teamlets, as we've heard about, guidelines and protocols and integrated care pathways. Very data-driven. You could say it's managerialist or bureaucratic. And the values that it embodies are efficiency, seamless, integrated, coordinated care, effectiveness or in relation to evidence-based guidelines, risk management, accessibility, and equity. But as I said, these are caricatures. There are some tensions already seen there, contested notions of quality, focus on person versus disease, care versus cure, and the way there's a shift of work going on and accountability onto primary care and to patients in this transition to this new sort of model. So I just want to now turn to this new model and talk about the notion of generalism and interpretive medicine. It's an important aspect of general practice care that I think needs to be preserved as we go about the transition. So in the new model, obviously aiming at improved access and quality, incentives are based on local accountability for those quality improvement outcomes and local flexibility to arrange services locally to meet them. The quality measures are going to be based on guidelines and care pathways drawing on evidence, best available evidence-based medicine. Now, monitoring the adherence to these pathways, of course, is an expanding industry in itself through quality improvement staff, and has led to this notion of scientific bureaucratic medicine, or SBM, which itself really is quite congruent with managerialist market-based ideas of managing publicly funded services. The evidence that EBM and scientific bureaucratic medicine draw on are often generated in select populations, secondary care settings, perhaps difficult to adapt to general practice care, where we face greater levels of uncertainty and we're focused on illness experience. And there is evidence that these approaches can lead to the medicalization of human experience, to disease mongering, and can undermine patients' own sense of agency and capacity. So in contrast, GPs tend to use more generalist approaches working with patients, exploring and interpreting their illness. They're drawing on evidence and clinical guidelines, but they're helping the patient explore their own illness experience within that. And the sorts of skills that GPs use to do that are curiosity and inquiry about a patient's life. They're using craft to help people integrate biological and biographical accounts of illness and build collaborations with partners and out into the community and with other health professionals as needed. And there's some evidence that these are highly valued activities that go on in general practice. Individuals value them, and that they can not only support individuals, but help to create creative, capable citizens who can then contribute to community engagement and empowerment. So it's not just a soft skill, it's a very important quality, I think, of general practice that needs to be preserved. So in summary, I think that's important, that statement down the bottom. I want to say that I think primary care reform must not be simply about optimizing cheaper community-based delivery of secondary disease-centered care through corporate-owned polyclinics. I think that's important. Which brings me, of course, to North Richmond Community Health Centre, which was started or established in 1974 in the blush of the Alma Ata Declaration. It was part of the Whitlam's Community Health Program, and it's an example of the community health centre movement. It had a community-based board, and now it has a skills-based board with community input. It's got multidisciplinary programs within it, dental, counselling, a range of allied health, GP, paediatrician, psychiatrist, addiction services, and now an injecting room. and it has a long history of social approaches to health and well-being. Lots of group activities, arts festivals, community arts programs, gardening, transport and trips, health education groups, working with refugees, culturally, linguistically diverse groups. And it recently won an award for its community engagement and empowerment in working with local called community leaders and ensuring access and excellent high rates of COVID testing and vaccination. Now, in the past, the GPs were supported by the community board to forego fee-for-service and be supported to be involved in all these community development activities. Well, that's certainly fallen by the wayside, and we could discuss why that is. But certainly, the community health centre movement has always been opposed by the medical profession in Australia and internationally, and has remained a rump. Nevertheless, there is still a large network of community health centres in South Australia, New South Wales and Victoria. In Victoria, there are 31 standalone, independently run community health centres. And the Grattan report explicitly highlights the importance of community control, and they talk mainly about Aboriginal community controlled organisations and newly emerging regional community health organisations. But what about building on what exists already? There's a strong network of community health centres there with a tradition of community control and engagement. So I'm coming to the end. What to do? As we've all said, what to do is a very important question. Well, as we've heard, this has been around a long time. This is an enduring debate, and borrowing from Sid Sachs, an enduring strife of interests. And back in 2008, 15 years ago, I was involved in a report to the Australian Primary Healthcare Research Institute, recommending exactly the sorts of things that are present in the Grattan report: flexible funding arrangements, quality improvement frameworks, strong mid-level organisations like PHNs with those roles, and investment in capital works, HR and IT. And we wrote about equity weightings as well. So it's been around a long time. We do need a new model, and I do support the Grattan model. It's great. You know, there's a lot of good stuff there. Just to reinforce my 3 points, I think any new model really does need to support generalist practice in all its aspects. And that means being particularly sophisticated about measuring patient and community experience, patient reported outcome measures, and the like, as important quality outcomes. And that does go on. For example, there's a care measure in Scotland, which could be a useful starting point. Equity weighting, I think, is absolutely critical. I mean, there's this hypothesis called the Victoria hypothesis, which some of you might know. Without this significant equity weighting, new health interventions are almost always adopted early by wealthier segments of the population, leading to greater inequity. So remember that there's a note in the Grattan report mentioning the coordinated care trials, the first round, saying that targeting additional funding to people with mild need is costly and brings no benefit. Okay. Now, finally, I want to end strongly. I say we need community governance and local control of new models. And why not begin with ACCHO's regional health organisations, community health centres, and existing cooperatives? And I do worry a lot about what corporates will do with this new model. And I'm sure we'll talk about that. So that's a personal perspective. There's lots more going on in the chat room I've seen already. But I know there's some GPs in the audience who will disagree with me. But in the end, I hope that's given a little bit of food for thought, and I'm looking forward to the discussion. Thanks.
Thank you so much, Peter, Danielle, and Dr. Furler. Yes, we're getting a lot of questions here. I'll do my best to try to work with them. I just would like to start while I'm looking into the questions here, asking, John mentioned just before that your support for an expansion of community health centers, right? But you mentioned that there is an opposition from the medical associations. Is that, I can't remember the term you used. How does that happen, and why do you think?
Well, I'm sure there are others here who are better able to speak to the sort of politics of that over the last 50 years. but the colleges have enormous power and lobby sort of power, and they're strongly defended fee-for-service models of care. How they've done that, as I said, I'm not a politician. I don't know how colleges wield power at a national federal level, but they certainly do. And the AMA, of course, are enormously strong and have resisted even really any sort of linkage to the current sort of health payment system that we have. I mean, most specialists in private operate completely independently of anything to do with Medicare items for the care that they provide. So there may be others who've got more helpful views about why that's come about.
I don't know if Peter or Danielle would like to add something about this matter.
Yeah, look, I think some of the medical bodies have been, I mean, Danielle mentioned they've been through a pretty bruising experience with the last trial where there wasn't really a financial incentive for people to participate. And I guess there's been some resistance over time. But one thing that's exciting is that the Minister, Mark Butler, has the task force he brought together has largely aligned. Their advice to government is pretty similar to the things that the Grattan Institute recommended. One of the things they've said we should have is a new blended funding model, and the minister's accepted that. And in his public communications, he's talked about it's really necessary to allow team-based care. So I actually think whatever the hesitation or resistance might have been in the past, it feels like the opportunity is opening up. That I think we might get real movement on that, which is really positive.
Right. I have a question here from Daryl Clunan. He's asking, if so many issues are social problems, shouldn't social workers be somewhere in the mix of those allied health supporters?
Yeah, so we talked about a range of different workers who could fit into this model. And we did talk about psychologists, for example. And we did also talk about some innovative models from the UK about sort of social prescribers who would connect people to community activities. And there's some emerging evidence they may be good. We've said that should be tested before it's rolled out more broadly. But I think that, you know, counsellors and social workers could be included in these kind of multidisciplinary teams in the future. And there's certainly evidence that when nurses can play a bigger role and they have a bit more time with patients, they can start to address some of the personal and social concerns that sometimes get lost in more traditional models of care. But also, Danielle, you might want to add to this too.
Oh, I mean, only to agree, Peter, but yes, certainly we see in some other jurisdictions, social work is coming in as part of the sort of new workforce of behavioural support workers who provide, you know, prevention services, mental health services, and are very much embedded in the general practice.
Can I just add? Yeah, we've just employed a social prescriber in our community health centre, and that's terrific. You know, the sort of social problems we see in the demographic of the groups using North Richmond are hardly going to be really eroded by or solved by someone linking a person to a group. I think I just find that sort of difficult to sort of to feel positive about. Look, it's a great start, but the idea of a community board inputting into social priorities of the region and mobilising the strength of all the staff in a community health centre, whether it's through advocacy or you know, outreach activities, or you know, that's got a much sort of stronger sort of feel to me. We used to have within our drug and alcohol services people who acted as care navigators, and they spent a lot of time on the street with people, really engaging very, very hard to reach groups and really helping them navigate the system. That's a bit of a gap for someone who's, I don't think a social prescriber does that. I think they say, here's your list of groups to get involved in. I'm not sure.
I think that's right. That's just one narrow part of it, isn't it? But I think the model of having a flexible budget that goes with the patient, having a big team, you can get these kind of really innovation in these specialised roles. and care navigators is one example. And then, I think, psychologists, really important for mental health needs as well. So yeah, I agree. This is, I guess what we're talking about really is the need for that bigger, more diverse team to sort of bring these different types and intensity of services together. But I think the commenter makes a great point. I think those kinds of services should be integrated.
We have a question from Lachlan Rodenberg. Do we have any thoughts on the Australian Medical Association's recent reactions to the progressive move by the New South Wales government to adopt increased pharmacy prescribing rights?
I can talk to that, or John, do you want to?
No, go ahead.
Okay. So my understanding is, I think if I'm right, that the Australian Medical Association has been fairly hostile to the proposals to have pharmacists do more, to be able to prescribe. I think one of the things in the context of this report, we've really talked about bringing a lot of workforce groups into general practice clinics. That includes pharmacists. There's very strong evidence from around the world that if pharmacists work within general practice doing things like helping people review and understand their medications, that has really big benefits. And our message to the Medical Association and the College of GPs is, I think it'd be good if they resist this idea of pharmacists doing more prescribing, which to some degree I support. But if they resist that, they should really get behind this idea of bringing them into general practice, because they do raise concerns about safety. But if this is part of one of these integrated teams that works together under the leadership of a GP, you would think that their concerns would be significantly reduced. So I guess that's what I'd say. I think if they've got that strong position there about the external pharmacist prescribing, then maybe they should be strong in supporting bringing them into GP clinics as we propose.
Noting
I think that's a reasonable point. Sorry, go on.
Sorry, just to agree, John, it also has the further benefit of ensuring that you don't have this fragmentation of care, of general practice care, as more clinicians in the community are taking on roles that GPs have previously delivered. And certainly if we look at what's happening with, and I'll forget the name of these, sorry, but if you now want a script to be delivered by a pharmacy, you can do an online service where a doctor will very rapidly prescribe you the script if you're choosing. This is not really a battle that the colleges are winning. And so we need to think about what's the best model for people to get better access to pharmacists rather than, what's happening by default.
Yeah, I certainly support what's just been said. Yeah, I don't have any insight into the AMA's reactions to it other than what we've already talked about.
Someone called Liz has made several comments and long questions in the chat. Could you come to ask, because I find it hard to summarize. Liz?
She would need to unmute herself.
Yeah, I just said.
Hi. Sorry. What were you asking me to do? To just go through the questions that
you made many points and questions. So if you want to ask one of them, but please be relatively brief.
I suppose I wanted to make a couple of points. I think the Grattan report's great. It's got lots of good ideas in it, but a couple of things. First of all, as I said, there's a great need to catch up, as is outlined in the report, but we have to go beyond that, I think. We have to try and think about what Australia will be like in 10 years' time. We know we're facing a huge impact from climate change and biodiversity destruction and possibly armed conflict. Sure, we're facing an increase in chronic disease, but we know we're going to get more infectious disease, antibiotic resistance, mental illness, unstable communities, family dislocation, unanticipated illness and injury and trauma from catastrophic events, inflow of a lot of displaced people from around the region. So we need funding models and service designs which actually support building strong relationships at the local level between multidisciplinary primary healthcare teams and communities, because without that, we're not going to get improved health literacy and the kind of preparedness we need for protecting community and individual health, and really rapid mobilisation. That has to have a local focus. It's got to have a lot of flexibility. It's got to have participative governance arrangements which build local capacity. And yet all of that needs to be able to be coordinated at a lot of levels in the country. So I don't think, my personal opinion is that models of primary health care that are based on small to medium business enterprises and corporatized practices which leverage the MBS are going to be appropriate at all. In fact, as I said, I think they're going to be a handicap. And opening up the MBS, even if it's improved to more allied health professionals, so-called, isn't going to be the answer. And I think we need a lot more community development as part of the team, and part of the team needs to be unpaid lay people in families and communities who are at the front line of primary health care in their families and communities. And if they're not part of the team, we're not going to make it. So you know, that's the first point. And I think the second point I really wanted to make is that, you know, there are a lot of good ideas in the Grattan report, but I think starting with what GPs need is really a bad mistake. I think we should have started with what does the public need, individuals and communities and the public, what's in the public interest, because it invites conflict between medical colleges and the AMA and government. If it's not seen if it's seen as a sectional interest, and it's really regrettable, because that's what happened ever since the mid-1970s when it comes to primary healthcare reform. It was seen as a battleground between medical colleges, old-fashioned disciplines, and it's bad luck that we've embarked on the same strategic pathway for policy debate in this area. We should have started with what's good for people, not what's good for GPs. It's just bad luck.
Yeah, thank you so much. Look, I think they're great comments, and they do highlight a few deficiencies in my presentation, and particularly the start. So one thing I should have said is that, although I started with disgruntled GPs, that you're quite right. The core point we're trying to make is chronic disease management is a known, huge and growing problem in our health system, particularly in general practice and primary care. And the other thing, and so that's what we're focused on, because we know that other countries who improved their general practice system are driving down the rates of avoidable hospitalizations for chronic disease. That's a small window into the big health gains that are being gained by better chronic disease management. And this is a growing and urgent problem, being by far the biggest disease burden in the country today. So really that was our objective and goal of our reforms, was how do we get better chronic disease management so people are healthy, because we're living longer and longer with more and more complex chronic disease. The second kind of, I guess, focusing factor for our work was we were really focused on this $250 million investment the government said about how they can improve general practice, and hopefully they'll do more over time. And Minister Butler said he'll be going back to the Treasurer for more, but we were sort of looking at that level of investment. What can we do with that money practically now? So I think you're right, there are big challenges over the horizon. Our focus was how do we deal with these challenges today? But I would say, I hope, that our recommendations also start to build some of this resilience and capability that you're talking about, that's going to be necessary for future challenges. For example, if we have the flexibility and we start shifting money to where the needs are greatest, maybe that can lead to some of the models you started, I think, to talk about community health workers, and more work on health literacy and preventive work, which we touch on a bit in the report. And we do talk to a degree about strengthening this regional governance, which is, giving them the levers and sophistication to be able to really look at a population and go, what are the emerging health challenges here? And how do we actually invest in tackling those? Because we feel that those regional bodies are currently too weak. And so whether it is a lot of the scenarios you talked about, hopefully that would be part of a stronger system. But yes, we couldn't solve all problems. And I take your point, particularly about the framing of the presentation today. But hopefully these are achievable steps towards that stronger, more resilient system for the future. noting that getting change in this portfolio is notoriously difficult. So it's just a question of how much we can bite off and expect governments to bite off. But look, really provocative and well-made comment, and I definitely agree with the thrust of it.
John, would you like to give a GP perspective there?
Yeah, well, just taking reverse Peter's point about what was missing around regional organisations and PHNs and having them do that sort of needs analysis and planning and community sort of consultation and engagement. I think that they need an enormous amount of sort of skill building in community in PHNs to do that. I mean, they've been trying to do needs assessments and plan services. They have had very little power to implement change, you're quite right, and have had limited funds. But, you know, if they're going to fulfill that role of community control, they need a hell of a lot of capacity building themselves to do that. Whereas, you know, something like a community health centre or an Aboriginal community controlled health organisation, much smaller, obviously smaller area, but they're much better at doing community engagement and community control and community input. So just to make that point. But, you know, as for addressing what a community needs, not what GPs need, well, obviously I think GP is an important part of the community. But I do remember that the National Centre for Epidemiology and Population Health back in the 70s, NCEF, published a report on Australia's primary healthcare system led by David Legg, I think it was, Paul Butler, others, in which they did exactly that. They tried to define what an area needs in terms of primary care services, medical, allied health, you know, a whole range of sort of potential sort of inputs into an area. And that could have served as, I suppose, as the basis for some pretty spectacular planning from, but it never did. But yeah, so the precedent of starting with what do we think an area should get, you know, weighted for the demographic of that area, what's going on in that area, what sort of, you know, primary healthcare resources should go to that. And maybe they would see, you know, that would be the beginning of an important sort of paradigm shift. Yeah, I sort of agree with that in a way.
I'd like to invite now Brett Osler to make his questions. I think he also tried to ask you here to unmute.
Yep, sorry. I'm trying to find the question back there.
There were quite a few, actually, I think.
Yeah, it's more a lot of statements. So number of issues I've seen in the sector includes medical practitioners evolving to managers, directors, and rather than doing what they're trained for, there's a percentage. Sorry, someone's just added a question, so I've lost mine. Percentage of the sector transitioning to cosmetic surgery, truncating access to standard healthcare procedures, and reducing capacity of qualified medical practitioners, nurses, etc., rather than a focus on dailies and qualities. We've got departments of health pointing that there's not enough evidence in areas, and where they used to be a significant funder of research, something around 70%, they're down to 30%. And private sector, largely from the medical sector, have flipped that figure around. Issues which will be significantly amplified as a result, such as COVID. And we're not going to have capacity. And the last point I made there is a lot of people have this sense of entitlement that I've paid my taxes. I should have unabated access to care despite not following what the best practice health enhancement or preventative health practices are. So what degree has the research gone towards addressing these, and what do you see as the future direction for them?
John, I hate to jump in all the time. Do you want to go first? Or
No, I couldn't actually quite hear that question.
Oh, okay, sure. Well, I'll have a go. Thanks. I think it was Brett. And lots of interesting points in there. I might have picked them all up, so just jump in if I miss important ones. I think the point you made about doctors and also nurses doing a lot of administrative work is a really good one and a common complaint and a waste of their skills. So there are other countries who bring in dedicated administrative assistants to do note taking and some coordination with patients, and they'll often sit in on the meeting. As someone else in the comments said, it's a lot of time the GP is not talking to me; they're looking at the screen. So there's if, for example, in Germany, I think they have something like 30,000. Danielle might tell me if I'm wrong, but they have tens of thousands of these administrative people who just help take that load. So I think that's one of the multidisciplinary things, is to take that admin work away. Something we didn't talk a lot about in our report was practice managers. But I think they're really important. And interestingly, the government's Strengthening Medicare Task Force said, they should have an important role. And I think that's part of the infrastructure that you need, not just to take the administrative work off the clinicians, but also to make the, put the structures around the systems around the team to help them work together well. So I think it's a great point you made. You picked up a point, I think, about declining investment in research, if I heard you right. I think one of the things we talk about is this is going to be really hard, to get these models right, both the design of the funding model and then a lot of the ways, oh, good, Brett, thanks for confirming, and then a lot of the ways that people work on the ground. So we really say that building in evaluation, testing, iteration into the rollout of these models is really important. That's a form of research that will be really applied and help things change. We talked to some people in other countries where that investment wasn't made and people got stuck with some early mistakes that really held back results for the community. So yeah, just to touch on a couple of the things you brought up there. But yeah, and I think you also talked about sort of some specialists moving into sort of cosmetic and maybe different kind of work that might be quite remunerative, but not really going to some of these core challenges. I think that's a really interesting question about why a declining share of people are drawn to GP work. I don't know if John wants to talk about that, but I also think that's a useful observation.
Well, I think just to segue, I think there's been quite a few comments just in terms of attracting people into general practice. Not that the Grattan report seems to feel that we need to attract people into general practice, but there's been quite a few people talking about salaried positions and why not within community health centres establish salaried positions. They're publicly funded organisations just like public hospitals, and why? And I'm sure a lot of young doctors would grab the chance for some security of employment, some reasonable conditions, and the chance to serve people with a high need. So, I think salaried doctors, I think there is a growing appetite for that, both in the young parts of the profession. And if you couch it in terms of, the AMA supported in hospitals, public hospitals, why wouldn't they support it in public community health centres? And as Janet McCalman's made up, has pointed out, this notion of community engagement control has been sorted out by community health centres and Aboriginal community controlled health organisations a long time ago, and they've been doing it for a long time.
Thank you for that. I was even going to ask Janet now to speak and make her questions.
Well, John has raised the critical point about salaried young doctors. I mean, they can't start a practice because they've got their big HECS debt. They can hardly afford rent, let alone buy into a practice. So it's just not happening. They want a salaried job. They don't want to have to pay their own insurance. They don't have to want to worry about running a business. They'd be very grateful for a salaried job where you're not paying for medical care by piecework, which inevitably produces unwanted consequences. So the abuse of the system comes from the fact that the more that it's easily abused, as all piecework is. And so, I mean, my own GP would love to be on a salary, she said. She'd love her son to be on a salary as a GP. And there's a desire for this. Now, the other thing we haven't talked about is where the GPs aren't, which is where they're most needed in our outer suburbs and in the country. Why not, therefore, part of the incentive of getting a salaried position is that you'll go and set up with other doctors and other health professionals in Craigieburn. At the moment, you've got to drive 2 hours to get to a doctor. Now, I know the coffee isn't as good, and I know the schools aren't what you want your kids to go to, but, you know, they have to work there. And the government could offer genuine incentives to people to work there. I'd hate to think that we've got to go through more inquiries, more bureaucracy, more studies. It's all been done. The research is well known. We don't need a lot of departmental control. Doctors know what to do, and health professionals. The last point I want to make is that if we look at where health systems work well in poor countries, they make a lot of use of ordinary health workers. And I live near the flats that were locked down during the pandemic. I had talked to Martin Foley about having community health workers, particularly for mental health, who spoke Somali and who are men, just to be able to get those very sick men, and there are a lot of them, to be able to trust the system. But no, we send out girls who are social workers who went to a private school in the eastern suburbs. It doesn't cut it with them. We have to use communities, and there's lots of people who have the capacity to do this sort of work. Fortunately, the local community health centre in Kensington has started to employ concierges. Now, remember the old community nurse, the district nurse in England, the bush nurse here in Australia. That interface between the clinic, the hospital and the home is absolutely vital. And those home visitors need to be dropping in on old people regularly, making sure they're eating their lunch, having a cup of tea or coffee with them, chatting to them, dropping in on young mothers, not the timed visit of the community health centre, of the maternal and child health centre, who's got a quota of how many times she can visit you. We've got thousands of people who could do these jobs. And as long as they're supported with a good peer network where they can get peer support, and they've got a good access to data, and that's my last point. One of our problems is that not in WA, where they have very good medical data management, our medical data management does in no way enable good management of people away from their core place of interaction with the medical system. So we've got to spend a lot on IT, and we've got to spend a lot on doing things better with the data we have. But the people, it would be a great way to increase our workforce participation and to draw into the workforce a whole lot of people who've come here, particularly as migrants, who otherwise can't get proper jobs. There are thousands of unemployed African young people with 2 degrees now, and they can't get to first base. Now, these are the people who we should be getting into the workforce. One of my friends, his father is a Somali doctor, but what has he had to do in Australia? Drive taxis. He could have been a perfect person interfacing with the Somali community on mental health. He does it informally, but he could have been put on a salary and put into a professional structure. So that's it. But we don't have to go around reinventing the wheel. People like John Furler and the people before him, back to heavens, these discussions were going on in the late 60s with David Legg and co. I remember them. And the Aboriginal Health Service has done it all. They've shown us what to do. It's brilliant. They
Thanks,
don't do
Janet.
fee for service.
Yeah. Thanks, Jenna. I see you're getting applause from all around the call. There's a lot of truth in all of that. I think just a couple of things. I think we agree on a lot, might disagree on a couple of things. So on the salaried roles, we recommend that for rural areas, where there's a thin market. The reason that I like the idea of a blended funding model in other areas is partly because, the evidence is pretty strong and there's lots of precedents. But I think having this flexible budget that can be used by the whole team to respond to the needs of the patients is good. Whereas salaried roles can lead to the individual worker focus that we have now through fee for service. So I think that, you know, the right design of blended payment model can actually help that a team work together. And particularly when, you know, in a lot of settings, the culture isn't in place. I totally agree about IT, and pleasingly, the government and the task force has focused a bit on that. Our work focuses on a little bit less. There's one other thing, sorry, there was so much in what you said. There's one other thing I wanted to respond to, which is, oh yeah, I guess there's a lot of people said in the comments, and yourself have said, look, community health has nailed it, ACHOs have nailed it, the Aboriginal controlled sector has nailed it. And we highlight in the report the great practices that those providers bring. And I do think that, you know, I really support them as amazing platforms. But I think we have a challenge here about the feasibility of making that the model for general practice throughout Australia, and whether that can be achieved both in terms of, you know, getting the investment from government, and also maybe attracting, you know, the many GPs who may not, you know, be used to or want to work in that setting. So I'm not to say that there's not huge to learn, and they've led the way, and we should try and replicate as much as we can. And I don't want to be a doomsayer about it, but I wonder whether we can really scale that across the system everywhere. I think there's inevitably going to be different kinds of practices. There will be GP-owned practices. Corporates have a big market share, and that's a part of the landscape. So I think changing the incentives and the funding model to push all providers in the direction we want to go for the best care might be more realistic than getting these models of community-controlled providers everywhere. You may argue that I lack enough vision on that one, and John, you may want to respond.
Well, just to say, I think you could make an argument for starting the first wave where those strong community control, community input sort of structures already exist. And we could learn a lot about how to safeguard important aspects of that model of practice in those communities before allowing the corporates, you know, at the sort of bucket, really. Because
I just worry that we end up, you know, yeah, I just worry that there's a lot of people who rely on those type of providers, and so if we're not pushing them in the direction we want to go, do they end up this residualized thing, holding onto fee for service, and then the risks to the community are greater? So that's my concern. It's a big strategic.
So you're protecting the private provider. I mean, the corporates are providing shocking medicine. It's terrible medicine, and you just simply have to produce a competitive and much better system, and to do it gradually. Focusing, we saw in the pandemic, we know in Melbourne, for instance, where the problems are. We name the suburbs. We don't need to do this in Kew. They've got more doctors than they can possibly cope with. Inner city's got more doctors than they can possibly cope with. We have to provide incentives to people to do medicine differently in those areas of greatest need. And there's that wonderful man, Hakesh Agarwal, who has set up a model for in the western suburbs. There are lots of people who know how to do it. And those practices probably need to be either cooperatives, maybe they can be community owned, there's all sorts of models. But we must not create a system where we're protecting existing corporates who are delivering very bad medicine.
I think there's a middle ground, which is to say, I agree with you that these new investments of putting the extra salaried team members in should be in areas of need, and then the new funding model should be rolled out preferentially in those areas. The only thing I'd say is I think we should allow practices in those areas to opt in, regardless of the type of practice, if they demonstrate a commitment to, the quality measurement, the team-based care and all that stuff, just not to rule out.
It'll all be fiddled. It'll all be fiddled. And the people who end up working in those corporate clinics are the students who came bottom of the class in the med school.
Yeah. Well, I think
that's the reality. People get terrible medicine, and they don't get continuity of care. They don't get integrated care. They don't get a holistic approach to their problems. They're just sent off with prescriptions. Countless stories of awful misdiagnoses and neglect. Because the whole model is wrong for medicine. You can't deliver medical care in that way.
Sorry.
Well, Peter's acknowledging there's problems with the fee-for-service system. I totally support everything Janet said. I'm just very careful of opening it up to whoever puts their hand up. I think, you know, we don't want one of these first wave practices to be in, you know, Surrey Hills or Camberwell. We want to hand pick, you know, maybe it's a corporate who's been doing well, who's got some established links with communities in and out of suburb, who's prepared to have some salaried and some blended payment sort of model going in there, but also an Aboriginal community controlled organisation, a CH, you know, a community health centre, you know, cooperatives, Mukesh, sure. But just saying, oh, you know, who wants to be involved? You know,
yeah, I think there has to
who
be
wants to be involved when they see all the money involved.
I know, and this is one of the lessons of the healthcare homes trial, right? Is that there was sort of not a threshold for participation. You didn't have to demonstrate that you were going to be having quality measures, you were going to report, and you were going to have a certain model of care. You know, some of them just said, "Oh, we'll take the money, we won't change." So I agree there has to be participation criteria, and you have to sign on. And the question is whether any of these, you know, GPM practices or corporate practices could demonstrate that. I think they should have the opportunity to be able to demonstrate. I think it should be carefully evaluated and monitored, but maybe we just disagree on, which is fine. I understand the concerns. Yeah.
You're advocating using public money to subsidise private business.
We already do.
If private business is to take public money, it has to accept regulation and it's got to accept being accountable. Now, just having someone come in as a bureaucrat and tick boxes does not actually guarantee that good medicine is being delivered. It just doesn't work that way, and it's too easy to fudge things and to cover up, and that's how rotting and bad medicine continues. There is a responsibility. If anyone takes public money, a school or a medical service, they have a responsibility to the nation, not to taxpayers, to the people of Australia. And you do not get that dollar for nothing. You've got to pay back with your commitment and your ethical behaviour, and to be giving the highest possible service. Otherwise, they can bugger off, frankly, because they're profiting off public money.
Oh, well, with that comment, which I don't think anyone here will disagree with it, I will pass to our last question. I would like to invite Tim Woodruff, who also made some interesting comments throughout the... I'm trying to ask you to unmute. Yeah. Okay.
I'm unmuted. Thank you. Thanks very much, Fernanda, and thanks very much to Peter and oh, where's she gone?
Danielle. Danielle had to go, and she.
That's all right.
Yes.
And, thanks for Peter and Danielle for producing this report. It is really an excellent directional paper that we've got there, and that is really wonderful. But I do also share the concerns of Janet, and I wonder whether she's read all those books behind her in that picture.
A lot of them, yeah.
Anyway, I really share her concerns about the potential for private enterprise to infiltrate or use an altered funding model to their advantage and not to the advantage of patients. And that's really the caveats that have to be applied to this kind of model. Now, I know that you're concerned about it too from the Grattan Institute. I understand that, but it's really just crucial that that be looked at really hard. I'd have to declare my interests. I am on the board of the community health centre that John Furler works at. So I'm very familiar with what John has been doing for the last 30 years and appreciate his insights tonight. I'm concerned about a couple of things in the Grattan report. The first is to extend fee-for-service to nurse practitioners, and you know, just extending fee-for-service is just totally the wrong way to go, in my view. It's just asking for trouble. We've done it in dental. We're just magnifying the problem, because fee-for-service with co-payments, you haven't got control. And that's what we see all the time. My colleagues, I'm a specialist, my colleagues just charge the earth, and patients are forced onto public hospital waiting lists, which are enormous. It's just not fair. And, you know, to open that up to other practitioners rather than closing it down just seems to be the wrong way to go. I can understand that you might be trying to work things through, but I still think it's the wrong direction to put into a report. In terms of whether we go for blended payments or salaried, Janet, I totally agree that the aim should be salaried. We've got to get there. Politics is reality. And there's no way that next year we're going to have salaried doctors all over the place. It's just not going to happen. In 4 years' time, it's not going to happen. We have to work the system. That's what, so we have to introduce blended payments. Really good idea. Gradually build that up. And the crucial thing, which I would totally support from John, and which in fact we've worked on together, is to make sure that socioeconomic status is key to those blended payments, really key. I'm a bit concerned about the suggestion that we go for comorbidities as an extra way of distributing blended payments. And the reason for that is the potential for cream skimming. You would be aware of that. And it's really just a potential kind of making it much messier. But if we can do it, we can do it. And with the feedback that you're envisaging, Peter, that's fine, but it really has to be latched onto very closely. It's a Whitlam-esque view that you have of turning around the health system, and I really appreciate that. But this, we're looking at the politics, we've got to realise that this government, although very different from the previous, is not Whitlam-esque. It is not going to suddenly change the thing. It is not committing anywhere near to funding in the immediate short term to the degree that the health system needs. I've got a question now very specifically to the Grattan Institute team, and basically it's you, Peter, now, is what do we do now? What do you think of the ideas that we have put, John and I have put, to the minister to do something straight away? We could, for example, today or tomorrow, he could say, let's increase the bulk billing incentive for GPs, for pensioners and healthcare card holders. They could do that tomorrow. Probably doesn't require legislation. If it does, it'll sail through Parliament. Peter Dutton wouldn't dare oppose it. We could make those patients suddenly be able to access care because their GPs are paid a lot more. Bang. And this is a problem that we have now. He said it's, the minister has said, a disastrous state, a crisis basically. We're seeing bulk billing rates drop. We can do something about it tomorrow. But he doesn't. He wouldn't. The second thing is to immediately start work on socioeconomic status being a condition of the degree of payment, an adjusting factor of the degree of payment of the practice incentive schemes, which can earn a GP practice $50,000 a year or something like that. And I mean, if you make that according to socioeconomic status, it's already adjusted for gender and age. Let's add in mesh socioeconomic status straight away. That can be set up and it won't interfere with any of the other plans. In fact, it will set it up to institute the kind of thing that you've been talking about, which is adjusting for a socioeconomic status. But they're things that we can do immediately. The Grattan plan doesn't reach, only reaches 1,000 practices over 3 or 4 years. No, that's fine. That's great. I understand the complexity of instituting such a policy. But what do we do now? What do we do to stop the crisis in bulk billing? That's what I want to do.
Yeah.
Over to you.
Thanks, Tim. So I'll just focus on that last one, I guess, is the big one, right? Because we could go through the corporates and the fee-for-service nurse practitioners, whatever. But I think the big one's the last one. What do we do now? The boring answer is we didn't look at that. so because we thought the government's been over years they've tinkered and tweaked and stabilized a system that's fundamentally not fit for purpose for the long term. So we focus on how do you get that long-term system. So we haven't done the in-depth work on what to do immediately, to be fair. So but I think to your point, what I would say about that is, I think where you're going, which is, I feel like they will also have to invest in the system because of inflation, because of the long-term impact of that freeze. They will have to inject some more money to stabilise the system, in my view. And I think that's some of what the minister's foreshadowed as well. I would personally think that tipping it into a rebate across the board is not the right solution. When we know that the greater pressures are in areas with lower co-pays where bulk billing is falling. And also literature shows that, essentially the people who were co-pays in the past were probably not missing out on care as a result. But as the bulk billing rate declines, we get into that risk with people who are worse off. So I would say that anything to stabilise or tip money into the existing system should probably be something along the lines of what you're talking about, which is to say to increase bulk billing incentives for consultations, for example. It would be a better way to go than the rebate, just boosting across the board. So I think what you're getting at. I haven't done the work on the modelling or the costings to really say exactly what it should be, but directionally, I think that's what I would think would be better. Does that answer your question?
Yep.
And absolutely, we can't. Yeah. I'm really interested in the minister's choice about sequencing here, right? Because he put out this thing from the task force that these are all the long-term directions before he put in any money to stabilise a system under great strain, which I actually think strategically may have been a positive move, to start to create a vision for the future before you sort of neutralise the challenges or start to minimise the challenges today. So anyway, I think it's good to put that long-term vision first.
Well, I think unfortunately we are running out of time. So unless John and Peter want to make any final comment or statement.
I'll just say that I've really enjoyed this session and the great knowledge and passion of the participants and the challenging questions for me. So thank you very much.
Yeah, likewise. It's been a great discussion, and thanks, Fernando, and thanks, Peter and Danielle, and all the other contributors.
Yes, it was very lively and interesting, and some things were actually very complicated. I think I'm going to have to watch this again, and it will be in our web. We record the talks, and it will be in our website soon. So anyone who wants to review and take a look again will be able to. So I want to thank once again Danielle, who's not here anymore, and Peter and John, and everyone who participated. I will now pass to Jeff McCracken-Hilson, who is our the chair of the Victoria branch, and he will just say some final words. Jeff?
Yeah, thanks. Well, it's getting late, so I'll be brief. That was a really fascinating event. Thanks to our speakers and thanks to the many contributions from the floor. We had a debate, which is great. That's what we love to have. And as I would say about Fabians, we're all on the same side. We're all aiming for the same kind of result, but there are different ways of getting there, and which the debate is vital on that. I'd just like to also mention that those people who are on the call, if any of you are not members of Fabians yet, please join and help to grow this organization, that we can carry on doing all the good things that we do. Thank you very much. Anything I've forgotten?
Thank you.
Yeah. Okay. Thanks,
everyone. Good night.